So the next talk is an interesting talk because we have several new approvals in the space of immunotherapy for ALL. The goal of this talk is to review all the approved immunotherapies in ALL and to understand the side effect profile and management of these immunotherapies, because they are bringing a whole set of toxicities that have not been seen so far with treatment of ALL. There are several targets that are present on ALL that could be potentially be used for targeting. Some of these are approved and some of them are in clinical trials. The biggest one is CD19, which is present in about 90% of B-cell ALL. And there are two approved drugs that can target it, Inotuzumab and CAR T-cell, which we'll all go through in detail. The second target is CD22, which is present in about 65 to 80% of B-cell ALL, and there are treatments that are targeted to that. The first one is Inotuzumab ozogamicin, which is an antibody plus chemotherapy combined to use an antibody-directed cytotoxicity. The second is Rituximab, which is a naked anti-CD22 antibodies. It is in clinical trials currently, and CAR T cells directed towards CD22, which are also going to enter clinical trials soon. The third target is CD20, which we all know has an excellent antibody against Rituximab and Ofatumumab. Rituximab has been incorporated in patients with CD20 positive ALL, while Ofatumumab is in clinical trials. CD52 is also present in a subset of ALL patients. Trials with Alemtuzumab are ongoing to see if that can improve responses and long-term survival. So we'll now go through one by one each of these immunotherapies. The first one is Rituximab. Rituximab is shown to have poor CD20 positivity, shown to have poor prognosis in patients with B-cell ALL, and the positive subcategory is basically anybody who has a CD20 positivity over 20%. It was considered positive for most of these trials, and when Rituxan was incorporated with hyper-CVAD, to the left is hyper-CVAD with Rituxan compared to a historical cohort of no Rituxan and just hyper-CVAD. The patients who got Rituxan had an increased both CR duration, which is the first curve, and increased survival with Rituxan compared to no Rituxan, which was a historical cohort. Interestingly, this benefit was only seen in patients who were less than 60 years old. There is no benefit to adding Rituxan over 60 years. So our standard is to add Rituximab in patients with treated with hyper-CVAD under 60 years old. To the right is the more Larson regimen-like regimens, which were combining CD20 with multimodality chemotherapy. And again, Rituximab was superior to control in combination with multimodality chemotherapy for all events that you can think of: survival, cumulative incidence of relapse, death, and overall survival. Rituximab was superior. Again, in this study, patients who were under 60 were the people who were benefiting from it, and over 60, there was no benefit to adding Rituximab. So for both kind of chemo regimens, the data was identical. The second immunotherapy that I would like to focus on is Blinatumomab, which is a bispecific antibody that engages CD19 on one hand, which is positive in 90% of ALL, with the body's CD3 or the T cells at the other, and induces redirected lysis of the tumor cell, because the idea is that the T cells in patients with ALL are not able to recognize the tumor cell, and blinatumomab facilitates this by binding to both and increasing lysis. Blinatumomab was approved for 2 indications for ALL, and the 3 trials that led to that approval, we're going to go through them one by one. The first one was the TOWER study, which enrolled Philadelphia negative B-cell ALL with a 2-to-1 randomization. Adult patients with relapsed or refractory B-cell ALL identified as either they were primary refractory or they were untreated after first relapse, with the remission duration lasting less than 12 months. So these are people who are not likely to get a response with chemotherapy again, or untreated second or later relapse, and anybody who had a post-transplant relapse were all eligible for the study. Blinatumomab was given in cycle 1 with at the dose of 9 micrograms per day on days 1 through 7, and then escalated to 28 microgram per day for the rest of the month through 28 days. The reason this was given this way is that blinatumomab is associated with a cytokine release and inflammatory a reaction with fevers and sometimes hypoxia and neurological complications, and giving this step up was shown to be safer in patients. Blinatumomab is usually pre-treated with steroids in order to reduce some of these reactions. Cycle 2 through 5 were given in 42-day cycles, so it would be 4 weeks on and 2 weeks off. And at that point, 28 microgram was given straight up without the escalation, again needing steroid pre-medication for cycle 2, but not after. And then maintenance was given from cycle 6 through 9 in similar cycles, except that they were 84-day cycles. The randomization was with investigator choice of chemotherapy. If you look at the results, in terms of overall survival, blinatumomab was superior to chemotherapy. The rate of CR was 42% overall, and 80% of those patients had an MRD negative remission. Chemotherapy arm median survival, as you can see, is low, 4 months, with blinatumomab 7.7 months. If we censored at the time of stem cell transplantation, this benefit was continued, and it was superior at that time as well. If you look at the subgroup of patients who were treated on the trial, blinatumomab was effective in most subgroups with regard to age, history of previous stem cell transplant, or having a bone marrow blast count less than 50% or more than 50%. However, there was one group that I would like to call out, which is the 3rd or later relapse, where the efficacy was not shown, but the other subgroups were okay. The second study was ALCANTARA study, which is for Philadelphia positive ALL. So the same population, except that they were Ph positive, and they had to be refractory to at least one second generation TKI, or intolerant to imatinib as well as a second generation TKI. This was not a randomized study. Blinatumomab was given in the same fashion as the TOWER study. And if you look at the long-term relapse-free survival and overall survival, blinatumomab still did very well with at least 6.7 months survival, median survival of 6.7 months. The CR rate was 36%, which in a patient with relapsed ALL is actually helpful, and that led to its approval for Philadelphia positive ALL as well in the refractory setting. So the third question was, we all know the importance of MRD in patients with ALL. There is also data that if we send people to transplant with an MRD positive a bone marrow response more than 0.1%, these patients are generally, all of them relapse. And the idea is that could we send people into a better transplant by achieving an MRD negative state? The BLAST study looked at this precise question where patients who were older and had received chemotherapy, at least 3 chemotherapy blocks, any standard chemotherapy was okay. They were in CR but had an MRD positive response with more than 0.1%. Patients were given 15 microgram per meter squared of the drug for days 1 through 28. It wasn't up titrated like it was in the previous study, because the concept is if the volume of disease is low, you're less likely to have cytokine release complications. Treatments were given up to 4 cycles. The median number of cycles given were 2. And if you look at all the subcategories of first, second, or third CR and look at the MRD response, it was 82%, 71%, and 50%, which was very impressive. This was true for all levels of MRD detection, and the drug is approved for an MRD positive CR as a bridge to transplant, or if they're not transplantable, to just continue with the cycle. Most patients achieved an MRD negative CR with 1 cycle, but some patients did take up to 2 cycles to have an MRD negative state. So now with the Inotuzumab approval for these 2 indications, MRD positive and relapsed, there are some side effects that we have to consider. Cytokine release syndrome, the severe, which is generally manifested with fevers, hypotension, hypoxia, is found in 5% of these patients and very responsive to steroids. Sometimes Tocilizumab, which is an anti-IL-6 receptor antibody, could be used for this, but for most patients, the CRS is not as severe as you see in CAR T cells, which we'll talk about. Neurological toxicity in the form of tremors, insomnia, headache, sometimes confusion has also been reported. For grade 3 severe events where patients are not able to talk or are not arousable, the drug has to be interrupted, and they're all reversible once the drug is interrupted. Lymphopenia and reduced immunoglobulin levels are seen in about 25 to 30% of patients. As you know, CD19 is present on mature B cells as well, so it can impact those cells too. However, the rate of infections that have been seen with Inotuzumab are not any different than what we would expect out of a relapsed and refractory population. The second immunotherapy that I would like to talk about is Inotuzumab ozogamicin, which is a CD22 antibody linked to calicheamicin. Calicheamicin is very toxic, as you know, when given by itself, but the idea of an antibody-directed cytotoxicity was explored with this drug in patients with relapsed B-cell ALL. All patients were adults with relapsed after 1 or 2 previous induction chemotherapy. Philadelphia positive B-cell ALL patients were also enrolled under the study if they were refractory to at least 1 TKI and standard chemotherapy. Patients were randomized to Inotuzumab versus chemotherapy investigator's choice. Inotuzumab was given at weekly dosing, and then once CR was achieved, it was given days 1, 8, 15 every 28-day cycle. And here were the results. If you look at the remission rates, about at almost like 80% got into a CR with the Inotuzumab arm outperforming the standard chemotherapy arm. Same thing was for progression-free survival for both groups. The overall survival initially seemed like it was sort of superimposed, but on long term, actually the Inotuzumab group did better than standard chemotherapy. Now, if you look at the subgroup analysis on this, if patients were subcategorized as to the duration of the first CR, the kind of salvage, first or second, or age, again, Inotuzumab ozogamicin outperformed chemotherapy. But there's one subcategory of cytogenetic risk, which is the translocation 411, which was the one category that it seemed did not work, and that just tells you that this is a disease biology that is very refractory and resistant, and perhaps that is not a subcategory that the drug works as well as in the other subcategories. But otherwise, CD22 expression, the percentage of bone marrow blasts, whether somebody had a previous transplant or not, the efficacy was similar. The side effect profile of Inotuzumab is very unique. The liver function abnormalities are pretty common, 20% in the Inotuzumab arm versus 10% in the chemotherapy arm. The hyperbilirubinemia is the same, 15 versus 10 in the chemotherapy arm. The patients who develop high bilirubin and it does not go back to their baseline at the end of the cycle have an increased risk of developing another toxicity of Inotuzumab, which is veno-occlusive disease that was in the trial was seen in 11% of patients versus 1% in the chemotherapy arm. And VOD was seen up to 2 years after randomization of the trial. There were several risk factors for veno-occlusive disease that were identified. One being ongoing bilirubin elevation prior to transplant, because a lot of these patients underwent stem cell transplant, and that itself increases the risk of veno-occlusive disease. If the patients were heavily pretreated with chemotherapies, patients who had a prior HSCT or stem cell transplant were at risk, and also the conditioning regimen. A lot of the alkylator or melphalan-based conditioning regimens have an increased risk of VOD, and patients who got Inotuzumab and that conditioning regimen also ended up having a high risk of VOD. And all of this increased the post-HSCT non-relapse mortality in these patients. So if you have somebody who is young and about to go to HSCT, and Inotuzumab is being used as a bridge to that, these are things that to consider when you're choosing the drugs. Cytopenias, thrombocytopenia particularly was common, 42%, and dose reduction guidelines are in place for platelets that do not recover back to baseline in CR. There are several ongoing trials combining these two drugs, blinatumomab and Inotuzumab ozogamicin, with chemotherapy or TKIs. In older patients, there is a trial with preliminary data with using mini hyper-CVAD, which is like a lower dose of hyper-CVAD chemotherapy, plus Inotuzumab, CVP and Inotuzumab, TKI plus blinatumomab, as I had discussed earlier, and in older patients, chemotherapy using like a Larson-like regimen with blinatumomab is undergoing trials right now in a randomized fashion. In young patients, pediatric patients, and these are the patients who we would generally not transplant if MRD negative, pediatric inspired regimen in combination with Inotuzumab is also undergoing clinical trials to see if better CRs and long-term survival can be achieved. The last giant is the CAR Ts, or the chimeric antigen receptor modified T cells. CAR T cells, the approved CAR T cell, which we'll talk about, I just want to talk about in general how these CAR T cells are being manufactured and how the patients are going through it. Patients who have relapsed ALL are undergoing a apheresis procedure to collect white cells, and they are then shipped, cryopreserved, and shipped to the manufacturing facility where the T cells are being enriched. The cells are then being transfected by a lentivirus and a CAR gene. The idea of that is to identify CD19 as the target for the approved CAR T cell, and it is the intracellular domain is a co-stimulatory molecule which is responsible for the enhanced kill or cytokine release that is needed for these cell toxicity. as these cells are being prepared, simultaneously the patient is being prepped for receiving the CAR T cells. The whole process can take about 3 to 4 weeks for the generation of the CAR T cells. The patients are given lymphodepletion conditioning, usually a combination of fludarabine and Cytoxan, in order to cut down the patient's native T cells so that the CAR T cells can do their job. And once the lymphodepletion is done, at least 2 days after, somewhere between 2 to 14 days is when the CAR T cells are being infused to patients, and then monitored for all the side effects that will happen. We're going to talk about that in a minute. The trial design that led to the approval of Tisagenlecleucel, if my son can say that at 5 years, I'm doing really well. The pediatric and young adults with relapsed and refractory B-cell ALL. And it's interesting how this whole screening started. Just tells you how it's not easy. 107 patients were screened for the trial for refractory B-cell ALL, but 88 enrolled, and out of the 88 that were enrolled, 68 were actually treated. And what happens with this drop is that many times patients cannot survive the period of CAR T generation, and their disease gets out of control, and that's why they cannot be treated. 53 of the patients who actually got the CAR T cells actually had to go through some kind of chemotherapy outside of the conditioning regimen in order to control their disease so that time can be given for the CAR T cells to be generated. After lymphodepletion, as I said, CAR Ts were given 48 hours after completion of chemotherapy, and this led to the approval. It is currently approved for up to age 25 with primary refractory ALL or in second or more relapse. And if you look, the endpoint was actually CR at 6 months because this was looking at a very refractory populations. Many of these patients had undergone multiple chemotherapies and HSCTs. At 6 months, about 70% had achieved a CR, and of the patients who did achieve a CR, at about 24 months follow-up, some of these are still ongoing, while some of them have started to relapse after the 6 months. But the trial met its primary endpoint of 70 to 80% CR, and the drug was approved on that basis. The survival, as you see, has been ongoing for some of these patients for up to 24 months. And if you look at the CAR T cell, you can detect the CAR T cells in blood. And if you look at the CAR T cells in follow-up, you can see that some of these are persisting for a pretty long time. So the concept of these cells is that once they're recognizing the antigen, they're able to self-generate and kill the leukemia cells. And this persistence of CAR T cells has actually been linked to these ongoing CRs that are being seen for this the trial. Now, managing the side effects of CAR T cells is a huge problem, and I think the development of these drugs have been slow because of this precise problem. Cytokine release syndrome, the incidence is pretty high compared to what we have seen in blinatumomab. 80% of patients go through it, 50% are serious. And when I mean serious, they're actually patients who are in the ICU with multiple pressors and are intubated for their ongoing CRS. There are some risk factors, including a high disease burden or escalating white cell count even after lymphodepletion that leads to these a higher chance of CRS. It is very important to recognize the presence of fever and tachycardia is usually the prodrome that precedes the CRS. Early use of Tocilizumab, which is an anti-IL-6 receptor antibody, has been shown to reduce morbidity and mortality in these patients. Tocilizumab, once given, usually works pretty quickly in a few hours, and repeat doses can be given at least 12 hours apart if there's ongoing CRS. Steroids are currently used as a second-line agent for managing CRS. There is some concern that the steroids might decrease the efficacy of CAR T cells, and that's why tocilizumab, that is anyways very effective in managing these CRS syndromes, is being used as a frontline for managing cytokine release syndrome. The second side effect is neurological toxicity, which the incidence is again pretty common. 72% of patients get it, 21% are serious, leading to cerebral edema or coma or like a non-arousable state. The median time to onset for this encephalopathy is 6 days. For cytokine release syndrome, it's usually 48 hours. But while CRS can go away quickly with giving tocilizumab, encephalopathy can be prolonged and sometimes has been seen up to like 50 days from the onset of the symptoms. It is not always related to the CRS. It can happen in the absence of a CRS or after CRS resolves. So it's a little bit different, and the exact mechanism of why patients get it is not known, except that there might be some a disruption of blood-brain barrier and endothelial dysfunction that could do that. Patients have headache, delirium, encephalopathy, tremor, and sometimes mutism and aphasia. The standard of care for this is steroids, which is helpful in reducing the symptoms from encephalopathy. The third thing that has been seen with CAR T cells in a prolonged fashion is B-cell aplasia, because these cells are so potent at killing CD19 as a target. 40% of patients actually have prolonged B-cell aplasia, and it can occur in patients in CR up to 1 year after the CAR T cells have disappeared from blood. Standard infection prophylaxis are in place, and immunoglobulin replacement is actively done to keep the levels more than 500 milligrams per deciliter. And as I said, they can persist for a while, so no live vaccines. Now, with immunotherapy, we have now 3 drugs that are approved recently, and Rituximab, which has been around for a while. There are several challenges for using immunotherapy in ALL, and some of these challenges are more for CAR T cells, but things that have to be talked about and considered is, first one is relapse. There are patients who are relapsing after CAR T cell use, and sometimes that's happening because there's an antigenic escape. It can either happen because the CD19 antigen itself undergoes a modification and the CAR T cells are unable to recognize them, or there's a CD19 clone that actually grows as the CAR T cells kill the CD19 positive cells. So one of the challenges to how to overcome that, and there have been attempts at using CAR T cells that recognize 2 antigens, not just CD19, but in combination with others like CD123, that could be helpful in order to prevent this antigenic escape. The second big issue is safety, because the big issue with our patients, with all of the CRS that happens, is how can we actually limit these off-target effects and better characterize the host in order to understand who are the people getting these bad CRS or neurotoxicity, and there have been attempts to identify such patients. And the other way to kind of increase safety is potentially the use of suicide genes in the CAR T cell itself, which could kill the CAR T cells via an antibody-directed mechanism. And that way, if somebody's actually very sick, we can kill the CAR T cells before they cause any more damage. Enhancing efficacy, so not everybody is obviously responding. So again, using dual targets would be one way to enhance efficacy, to see if more people can respond to the treatment, and more importantly, having sustained responses. And the fourth one is universal availability. So the issue with CAR T cells, as I have said, that auto CAR T cells take 4 weeks, up to 4 weeks of generation. So, and some patients cannot actually wait for that. So what can be done about it? And there have been a couple trials looking at off-the-shelf CAR T cells used from allogenic donors that could be used in patients to negate this whole wait period, but these are all undergoing clinical trials using the CD22 target as well. That concludes my talk.